Welcome to the RadOnc Smart Review Head and Neck Cancer series.
Today we're embarking on what I think is a really high-yield review. It's focused entirely on functional outcomes and survivorship in OPC, or oropharyngeal cancer.
Right.
And this isn't just, a clinical topic.
Yeah.
It's really a framework for how we treat these patients, and critically, how boards are going to test whether you understand the long-term impact of your dose distribution.
Absolutely. Because when we talk about survivorship in this context, we aren't just reciting a checklist of follow-up visits.
No, not at all.
We need to know if we understood the functional price of cure that we asked the patient to pay. And, whether we used every tool we had, specifically our constraints, to try and mitigate that price tag.
That's the perfect way to put it. This discussion has to be constraint-forward.
Yes.
It's built on the premise that the numbers you draw on the planning CT directly dictate that patient's quality of life years later.
So for this review, we are using the conventional fractionation constraint library. Think the QUANTEC consensus standard, major protocol goals. That's going to be our organizing language.
Right. You need to be able to say these numbers out loud,
Yes.
justify them, and explain the anatomy they protect, especially when you're under that exam pressure.
Okay, so our mission today really rests on 4 specific pillars. First, we're going to anchor survivorship in 2 very different clinical cases. A classic chemoradiation path versus, say, a TORS adjuvant path.
And that's to clearly define what expected function truly looks like based on that treatment intensity.
Exactly. Second, we are going to meticulously build the dose function logic for all the major late effects. We're going to tie the mechanism of injury to those non-negotiable constraint numbers.
We really want you to understand not just the what, but the why.
Third, we will compare the functional outcomes between those transoral surgery pathways and definitive radiation, and we'll use insights from landmark studies like ORATOR and ECOG 3311.
Which is so important not just for boards, but for that crucial patient counseling you do every day.
And finally, we'll lay out a clean, board-ready survivorship schedule and a pragmatic complication management framework. This should give you the tools to really improve the survivorship experience for your patients.
Let's jump right into the clinical context then, because that board mindset, it always starts with the patient experience.
The core concept here, and I think boards are really testing this, is whether you recognize the functional trajectory based on that initial treatment intensity. So let's look at 2 patients. They're both cured, but they're having dramatically different survivorship experiences.
Okay, so let's start with case A. This is our prototype post-definitive chemoradiation survivor. He is a 54-year-old man, and he's now 12 months out from definitive chemoradiation for a P16 positive T2N2 a base of tongue cancer.
A very classic presentation.
Absolutely. He got 70 grays and 35 fractions with concurrent cisplatin, so bilateral high-dose treatment. And the great news is he has no evidence of disease.
Which is fantastic. But now, let's focus on his functional status at 1 year out.
Right.
He's reporting persistent, moderate to severe dry mouth, significant difficulty swallowing solid foods. He's avoiding anything hard like steak or bread.
And he's lost 15 pounds since treatment. That's a huge red flag.
It is. Crucially, he's not feeding tube dependent, but his diet is really limited. He relies on soft, high-calorie foods. His MDA-DI composite score, which we'll get into, is 68.
Okay, so now let's contrast that experience with case B.
Right.
This is our post-transoral surgery, or TORS, adjuvant pathway survivor. She's a 48-year-old woman, 8 months out from TORS, plus adjuvant radiation for a P16 positive T2N1 tonsillar cancer.
And the pathology was favorable, right?
Very favorable. Negative margins, no extranodal extension, or ENE. So based on that, she received 60 grays and 30 fractions, and it was primarily just to the surgical bed and the ipsilateral neck.
Her symptoms, you can imagine, are dramatically milder at 8 months. She reports, mild dry mouth, but it's isolated to the treated side, and maybe occasional difficulty with thin liquids.
And her MDA-DI composite score is 82.
So the core consult question for both of these patients is actually identical. What functional trajectory is normal, what surveillance is needed, and what interventions are actually going to move the needle right now.
But look at that gap, a score of 68 versus 82. I mean, on the MDA-DI scale, that is a huge difference in quality of life.
And I think that gap, that difference between a 68 and 82, that's really what we need to anchor this entire discussion around.
I agree.
It's the difference between that bilateral high-dose treatment that just necessarily compromises multiple OARs and a unilateral lower dose treatment that allows for functional redundancy. That difference is the DVH reality.
Absolutely. The patient with the 68 score is experiencing, clinically significant quality of life limiting dysfunction,
Mm.
while the patient with the 82 is dealing with mild, manageable issues.
And we can't let the board examiner or even ourselves see those numbers and not immediately trace them back to the constraints that were used, or maybe more accurately, the constraints that couldn't be met.
That leads us perfectly into structuring your response. Let's do a mock exam. You've just finished describing case A. The examiner looks at you and says, discuss your survivorship plan and counsel this patient on his expected trajectory. How do you synthesize this?
Okay, so I'd structure my response in two parts. First, you have to confirm the medical status, no recurrence. And second, you frame the functional reality based on the dose that was delivered.
Let's hear the full script.
Mhm.
How would you deliver that? Making sure to anchor the outcomes back to the treatment intensity.
All right, I'd say. This is a patient cured of P16 positive oropharyngeal cancer who now has survivorship limiting xerostomia and dysphagia 1 year out. First, I confirm no evidence of recurrence on physical exam and appropriate post-treatment imaging like a PET CT or a diagnostic CT performed 3 to 4 months ago. Then, I frame the expected late effects based on treatment intensity. Definitive bilateral chemoradiation to 70 gray commonly causes chronic, severe dry mouth and swallowing impairment due to high-dose exposure to bilateral salivary glands, constrictors, and the larynx. By contrast, a selected TORS with unilateral adjuvant radiation typically preserves better function due to functional redundancy. My survivorship plan is constraint-linked. I will maintain aggressive dental prevention because mandibular high dose combined with xerostomia creates high osteoradionecrosis risk. I will continue and escalate speech-language pathology with active swallowing rehabilitation given the substantial constrictor and laryngeal dose exposure. I will monitor thyroid function every 6 to 12 months after neck irradiation and screen specifically for nutrition weight loss, aspiration risk, and mood issues like depression. Function often continues to improve slowly over 12 to 24 months with active rehabilitation, but some chronic dysphagia and xerostomia are likely to persist, requiring lifelong management.
That script is the ideal framework. It immediately ties the patient's current symptoms, dysphagia and xerostomia, right back to the radiation plan.
Right. If you miss that linkage, you just sound like a general practitioner, not a radiation oncologist.
Exactly. And for boards, you need a quick way to catalog these primary, high-risk quality of life concerns. So we've structured this around the functional big four in OPC survivorship. Let's use a simple mnemonic, DXOH.
DXO. I like it. So that stands for dysphagia, xerostomia, osteoradionecrosis, and hypothyroidism.
And we're going to build each of these four critical late effects around the planning constraints that matter most, and crucially, explain the underlying mechanism of injury for each one.
All right, let's start with D for dysphagia. This is, I think, the functional issue we fight hardest to prevent.
It is, and it's such a diverse spectrum.
Mhm.
Residue, aspiration, a delayed swallow trigger, strictures, diet restriction, weight loss, and just severe social impairment.
Our job is to map those clinical outcomes directly back to the anatomical structures and the specific threshold doses they received.
Before we even get to the constraint numbers, let's make sure we're fluent with the assessment tools. These are often tested and are just central to patient management. We already mentioned the MDADI, the patient-reported outcome measure.
Right, scores run from 20 to 100, and higher is better.
The keyboard number for MDADI is knowing that a score below 60 suggests clinically significant dysphagia.
The kind that really impacts quality of life.
Exactly.
Right.
And may warrant more aggressive intervention. And equally important, a 10-point change in that score is considered the minimum clinically meaningful difference. So if case A went from 68 to 78, that's a real success.
Okay, and on the objective assessment side, you need to be fluent with FEES fiber optic endoscopic evaluation of swallowing.
Right, this gives you that objective, real-time assessment for aspiration events and overall swallow physiology. It's how we differentiate, pharyngeal weakness from actual aspiration.
And then you have FOSS, the Functional Oral Intake Scale, which is a simpler, diet-based grading scale that just tracks how many modifications the patient needs to eat safely.
Okay, let's unpack the constraint anchors that drive the physics of dysphagia prevention using conventional fractionation. We have to start with the pharyngeal constrictors, superior, middle, and inferior.
These are the muscles responsible for pushing that food bolus down into the esophagus.
Their failure leads to residue, pooling, and eventually aspiration. So the core board anchor, the say it out loud threshold for this structure, is that the mean dose goal for the constrictors should be under 50 gray.
And the why really matters here. Studies like QUANTEC have shown that above 50 gray, the rate of muscle fiber atrophy and subsequent fibrosis it dramatically increases.
It leads to mechanical failure, reduced pharyngeal contraction pressure. And if you're treating bilaterally to 70 gray, you're just blowing past that threshold. Chronic failure is almost guaranteed.
But let's play devil's advocate. For case A, that mean dose is impossible to hit. The high-dose target is the base of tongue and the bilateral neck. The PTV is getting 70 gray.
And that's the challenge. The crucial planning truth is that the constrictor constraint primarily applies to the portions outside the PTV high-dose region.
So in the elective dose bath.
Exactly. When we're treating nodal volumes up to 60 gray or 54 gray, we fight tooth and nail to keep the constrictors in those elective dose baths to that mean of 50 gray or less. You spare what can be spared.
Okay, next up, the larynx. This is so critical because laryngeal edema and reduced laryngeal elevation lead directly to aspiration risk.
And for this, we aim for a mean larynx dose under 44 to 50 gray when the larynx is not part of the high-dose targets.
You also need a specific DVH anchor to control the volume receiving high dose, which is what predicts that edema. A common target that correlates with lower edema and aspiration risk is the larynx V50 under 27%.
Meaning less than 27% of the entire larynx volume should receive 50 grays or more.
And finally, the cervical esophagus. I mean, strictures are less common now than with older techniques, but direct esophageal dose drives that risk.
Yes, so the survivorship forward anchor here is a mean esophagus dose under 34 gray. And that's to reduce severe esophagitis and all the downstream dysfunction that comes with it.
So if the examiner asks you to justify your dysphagia strategy, you need to connect these dots immediately.
This is how you do it. You say, my dysphagia risk is driven by how much of the pharyngeal constrictors and larynx reside in the elective dose bath. Because I know constrictor fibrosis is exponential above 50 grays, I aim for a mean constrictor dose under 50 grays outside the high-dose target. For aspiration prevention, I try to keep the larynx mean under 44 to 50 gray with a V50 under 27%, because those thresholds track closely with functional outcomes, edema, and subsequent aspiration risk.
Okay, moving on to the second part of DXOHX for xerostomia. This is often the most persistent quality of life limiting complaint. It's just a constant day-to-day misery.
It really is. It leads to diet restriction, speech fatigue, sleep disruption, and of course the catastrophic risk of dental decay. The underlying mechanism here is just irreversible damage to the serous acinar cells within the glands. They're just highly sensitive to radiation.
So we manage this with a functional gland-based strategy, really aiming for redundancy.
Right. For the parotids, which are the workhorse of serous saliva production, the definitive board anchor is non-negotiable. You need dose to at least one parotid under 26 gray.
And if you can hit that 26 gray on one side, you have a really high probability of preserving enough function for the patient to produce adequate resting saliva.
But let's challenge that a bit. The submandibular glands are equally important for basal saliva and oral lubrication. They contribute most of the mucus. Why not just focus on the parotid?
Because the submandibular glands provide that critical, thick, mucus-rich saliva that protects the teeth and lubricates the mouth at rest, overnight. Losing the submandibular glands is often a greater functional hit than losing the parotids for sheer comfort and caries protection.
That's a great point. And the goal there is a mean dose to at least one submandibular gland under 39 gray.
And that's often a harder constraint to meet than the parotid, especially in those TORS adjuvant cases where the ipsilateral submandibular gland is sitting right next to the surgical bed in high-risk nodes.
Yeah, some institutions might allow relaxing that up to the mid-40s. But 39 gray is the firm constraint goal you must cite. You're fighting for that one gland that is furthest from the PTV.
And then beyond the major glands, there's mucosal exposure. High mucosal dose drives taste changes, that sensation of dryness, and even severe chronic pain syndromes.
Which is why for the oral cavity, the goal is a mean dose under 40 gray when it's involved in the target volume, and ideally under 30 gray when it's uninvolved.
And you can't dismiss the smaller structures like the lips. Mean lips dose under 20 gray is a clean anchor. This is especially relevant to minimize chronic chapping and discomfort.
Okay, let's synthesize this into the board-ready move for xerostomia.
I would say something like this. My xerostomia mitigation strategy is functional and gland-based. I plan for a mean of one parotid under 26 gray and a mean of one submandibular under 39 gray whenever targets allow, because preserving one gland of each type provides optimal functional redundancy. I also aggressively reduce unnecessary dose to the uninvolved oral cavity and lips, as high mucosal exposure significantly exacerbates the subjective symptom burden, even when gland means look acceptable.
And this directly explains why case A, with the bilateral treatment, faces such high xerostomia. It's almost physically impossible to keep one parotid under 26 and one submandibular under 39 while covering the bilateral neck up to 70 gray.
Whereas case B with the unilateral plan had a preserved contralateral side. That MDADI score of 82 is perfectly consistent with mild unilateral dryness.
Okay, next up in DXOH is osteoradian necrosis, or ORN. This is the complication that really strikes fear into the hearts of survivors and clinicians alike.
It's preventable in planning, but it is absolutely punishing in survivorship.
The mechanism is critical here. Radiation exposure leads to a process we call the 3H's: hypoxia, hypocellularity, and hypovascularity.
So the radiated bone tissue is severely compromised. It's got poor blood supply, few active cells to repair injury, and low oxygen tension.
And ORN happens when trauma, usually dental extraction, maybe a sharp denture, opens a non-healing wound in this compromised bone. The bone just dies and the wound doesn't close.
And the risk is driven by high dose, hotspots, and patient behavior.
Exactly. For conventional fractionation, the primary constraint anchor is controlling that high dose to the bone. You want to keep the mandibular D max around 66 to 70 gray when it's feasible. Above 70 gray, that risk just increases rapidly.
And we also need DVH goals to manage the volume that gets that high dose. You can't have half the jawbone receiving 60 gray.
No. A practical institutional set you can cite for boards is aiming for mandible V40 under 50%, V50 under 40%, and V60 under 24% when possible. You have to be so vigilant about avoiding those small, high-dose hotspots right on the periosteum.
So for the board-ready justification for ORN prevention?
You'd say, I reduce ORN risk fundamentally by controlling mandibular high-dose and hotspots in my plan. I aim for a mandible Dmax around 66 to 70 gray, and I implement volume goals like V40 under 50% and V60 under 24% when feasible. The subsequent survivorship prevention is almost entirely dental. Meticulous oral hygiene, lifelong fluoride treatment, and absolute avoidance of elective or unsupervised post-radiation extractions.
That last point, the clinical prevention behavior, is a functional must-do. You have to have that pre-treatment dental evaluation.
Absolutely, to identify and address any non-restorable teeth or existing infections.
And post-treatment, it's all about fluoride, meticulous hygiene, and lifelong dental follow-up. And if an extraction is required, it has to be done atraumatically, often with hyperbaric oxygen or antibiotics, and coordinated explicitly with the treating oncologist.
You have to treat every post-radiation extraction as a potential disaster that needs multidisciplinary management.
Okay, our final component of the DXOH mnemonic, H for hypothyroidism.
This is such a crucial survivorship point, because while we're so busy fighting dysphagia and ORN, this silent killer of quality of life can easily be missed.
And what's interesting here is that while we try to spare the thyroid in planning if we can, the late effect itself is less about a single constraint number and more about surveillance discipline.
That's absolutely right. The rule for survivorship is simple and definitive. If the neck was irradiated, you check TSH every 6 to 12 months. Indefinitely.
Indefinitely. I think that's the key word.
It is. The gland is often in the elective neck field, receiving 30 to 50 gray. This can lead to fibrosis of the gland, making it underperform.
And the symptoms, fatigue, weight gain, cold intolerance, depression, they're incredibly nonspecific. They often get masked as just post-treatment exhaustion.
Right. If you don't build TSH monitoring into your routine care, you guarantee that a significant portion of your survivors will be needlessly suffering from treatable hypothyroidism. This is an absolute trap to forget on a board exam.
Okay, so let's transition from why these constraints matter to how we actually achieve them. We'll detail the planning workflow that ensures we honor those DXOH constraints.
Let's start with the physical setup. For OPC, the standard is a rigid, customized thermoplastic mask, usually encompassing the head, neck, and shoulders. And we use a shoulder pull device to minimize shoulder dose and ensure reproducibility.
And a bite block or some kind of tongue positioning device is often used. This is functional planning. If you can displace the tongue base or the soft palate slightly out of the highest dose region, you gain precious millimeters.
And those millimeters translate into better constrictor and mucosal sparing.
For imaging, it's a CT simulation, preferably with IV contrast to see vessels and nodes clearly. We need thin slices, 1 or 2 millimeters, and meticulous co-registration with diagnostic imaging like MRI or a PET CT.
Right, especially for defining that primary tumor and any suspicious nodes. But the critical step for survivorship, and where a resident really earns their stripes, is contouring.
You have to be meticulous with the organs at risk that map directly to our functional framework. We have to contour the parotids, submandibulars, oral cavity, lips, mandible, the entire pharyngeal constrictor muscle set, the larynx, and the cervical esophagus.
And never, ever forget the hard stop serial organs: spinal cord, brainstem, optic apparatus, and the cochlea. A marginal gain in parotid mean dose is never worth compromising the cochlea.
Okay, let's do a rapid-fire review. Let's call it the constraint card. This is the mandatory number set for conventional fractionation that you just need to be able to recite immediately and accurately.
All right, for saliva sparing and function,
Mean 1 parotid under 26 gray.
and mean 1 submandibular under 39 gray.
Got it. For swallowing protection.
Mean constrictors under 50 gray when feasible outside the high-dose target.
And larynx mean under 44 to 50 gray when not in the high-dose target.
With that, larynx V 50 under 27% is a functional DVA channel.
For mandibular ORN prevention.
Dmax about 66 to 70 gray, with volume goals like V60 under 24% when you can, fighting those hot spots.
Lower tract.
Cervical esophagus mean under 34 gray. That's a strong anchor to reduce stricture risk.
Okay, central nervous system.
Spinal cord Dmax under 45 to 50 gray. This is absolutely non-negotiable.
And for adjacent structures.
Cochleum mean under 45 gray, trying to avoid doses above the mid-50s. And for the brachial plexus and high neck plans, V60 under 5% and Dmax in the 60 to mid-60s range.
Now that we know all the numbers, let's talk strategy. What's the most common planning failure, even when the planner knows all these constraints?
It's prioritizing a prettier PTV DVH. Getting that PTVD 95 value exactly perfect at all costs over achieving a meaningful functional gain in the organs at risk.
It's the pursuit of perfection and coverage that costs the patient in their quality of life.
Right. We frame this using the trade-off ledger analogy. You are constantly balancing PTV coverage against OAR sparing. Every single monitor unit adjustment is a trade.
Let's use a practical example. Say your PTVD 95 is at 99.5% of the prescription dose, but your contralateral parotid mean is at 28 gray. Your goal is 26.
Okay.
If shifting a few monitor units slightly drops your PTVD 95 to 99%, still perfectly acceptable, but it improves your parotid mean to 25 grays, that's a positive trade-off.
It's a huge functional gain for a marginal, clinically meaningless change in coverage.
But here's the high-stakes bad trade-off. You squeeze the plan so hard to hit that 26 gray parotid mean that you compromise the mandible constraint, and you raise the Dmax on the jawbone to 72 grays right on the periosteum.
Ugh. That trade-off doesn't buy you better tumor coverage, and it introduces an unacceptable, catastrophic risk of ORN.
Exactly. The takeaway is this. You have to document the inevitable trade-off and counsel the patient before they even start treatment. Survivorship isn't just what you achieved on paper, but what functional cost you anticipated and proactively mitigated.
So let's talk about modality comparison. This is essential for counseling OPC patients. They are terrified of swallowing failure.
And the answer, which we can trace right back to our cases, is complex, but it's always tied back to dose distribution and treatment intensity.
The core benefit of the TORS pathway, especially in selected HPV-positive patients who have excellent pathology clean margins, no ENE, is the removal of the primary tumor.
Which means the adjuvant radiation target is smaller, often unilateral, and frequently a lower dose, like 60 gray max.
This avoids that primary mucosal dose bath and makes it far more feasible to meet constraints on the contralateral uninvolved side. You achieve that functional redundancy we talked about.
That's why Case B had the high MDADI score of 82.
Right. Now contrast that with definitive bilateral high-dose chemoradiation, our Case A.
Yeah.
You are radiating both neck sides, and the high-dose volume almost certainly involves major portions of the pharyngeal constrictors, the larynx, and both sets of salivary glands.
It's just physically impossible to meet the ideal constraints, which leads to that higher chronic xerostomia and dysphagia risk.
But we need to support this with the evidence. Let's talk about ORATOR and ECOG 3311. Let's start with ORATOR, which focused on dysphagia management.
The ORATOR trial randomized patients getting definitive RT to either standard care or prophylactic swallowing exercises initiated early during treatment. The goal was to see if exercises would universally mitigate late dysphagia.
And what did they find? Interestingly, the primary endpoint, the MD-ADI score at 12 months, was not significantly different between the two arms overall.
Which was a surprise to a lot of people.
It was. But here's the clinical nuance. The trial suggested that patients who had less severe baseline dysphagia actually saw a decline in function with proactive exercises, maybe from fatigue or poor adherence.
So the critical insight was that prophylactic SLP is most effective when you target it to the patients who really need it. Those with a lower baseline MD-ADI or those getting that high bilateral dose.
It's not a one-size-fits-all solution. It requires careful patient selection and engagement to really move the needle.
Okay, now let's look at ECOG 3311, which investigated de-intensification strategies after TORS in HPV-positive patients. This study directly addresses the difference between our Case A and Case B.
This trial looked at reducing treatment intensity, specifically, reducing the dose and/or chemo in patients who had an excellent pathological response post-TORS. The goal was to keep the great survival rates while reducing toxicity.
And the findings reinforce the functional benefit of de-intensification. The arms that received less dose or less systemic therapy, which correlates with better OAR sparing, showed significantly better long-term functional outcomes, measured by MD-ADI.
Exactly. These results, along with others, really solidify the counseling point. If your patient is eligible for a surgical de-intensified pathway, they have a higher likelihood of better long-term functional outcomes because of superior OAR sparing.
Just like our Case B.
But if they require definitive bilateral high-dose treatment, like Case A, cure rates are excellent, but the cost in dry mouth and swallowing is inherent and higher, and that requires aggressive planning and management from day one.
Let's circle back to our cases with this evidence in hand and decide on the next steps for management.
Okay, Case A, post-CRT, MD-ADI 68. This is the expected reality of bilateral chemoradiation at 1 year. It's mild to moderate, clinically significant dysphagia. Our job is confirmation and intervention.
So action. Confirm no recurrence. Aggressively engage SLP with active swallow exercises, understanding that consistent effort between 12 and 24 months can still yield functional recovery.
Right. And we treat the xerostomia with saliva substitutes, maybe consider sialagogues like pilocarpine. We maintain aggressive dental prevention. And that non-negotiable step.
Check TSH immediately. Fatigue and weight change have to be ruled out as thyroid-related first.
Okay, Case B, post-adjuvant RT, MD-ADI 82. This indicates good function, supported by that unilateral DVH mild issues. They're manageable. Our job here is really functional preservation.
Right. We focus on survivorship surveillance, lifelong dental prevention, and ensuring that thyroid monitoring is scheduled and maintained. We also educate her on late-onset changes and encourage her to report any regression in function immediately for a FEES assessment.
We really have to stress that toxicity management starts pre-treatment. Acute issues, mucositis, dermatitis, they resolve. But the late survivorship consequences are set in stone by the DVH.
That's why prophylactic swallowing exercises, aggressive nutrition support, and early SLP consults are crucial late toxicity prevention strategies. We have to be proactive, not reactive.
For chronic dysphagia, the steps are active rehab, getting an objective swallow evaluation like FEES if you suspect aspiration, and being ready to address strictures early.
For xerostomia, it's about symptom relief, and, most critically, it carries prevention. We're prescribing high-concentration fluoride and requiring lifelong dental follow-up, and you have to manage patient expectations. Counsel them that the dryness will likely stabilize but may never fully normalize.
And with mandibular risk, you must manage every dental need. Coordinate extractions carefully, minimize trauma, consider a protocol with antibiotics, and close follow-up.
Yeah, hypothyroidism, treat it immediately when detected. It's a lifelong commitment. We have to empower the primary care physician to understand the need for continuous TSH monitoring.
Okay, let's solidify the precise surveillance schedule, as this is a high-yield board question.
Physical exam with flexible laryngoscopy. That's usually high frequency early on, every 1 to 3 months for the first year, then spacing out. But crucially, follow-up must be lifelong annual after 5 years.
Recurrences are rare, but they do happen, and second primaries are a major lifetime risk.
For post-treatment imaging, like a PET-CT or diagnostic CT, that's usually done at a standard early benchmark, typically 3 months after definitive CRT to assess response.
And after that, subsequent imaging in asymptomatic patients is generally symptom-driven, not automatic. We don't want to needlessly scan patients who are doing well.
The critical anchor point. TSH is checked every 6 to 12 months indefinitely after any neck irradiation. That is a non-negotiable answer.
Dental surveillance is lifelong for anyone with meaningful intraoral dose or persistent xerostomia, regardless of their original treatment.
An SLP follow-up is symptom-triggered, but it has to be low threshold. Late swallowing events and functional decline, especially from progressive fibrosis, can develop years after that 5-year mark.
So if a patient reports a change in diet texture, they need an objective swallow evaluation.
Let's transition into some specific traps and pearls that examiners use to test your knowledge and speed in this survivorship area.
Okay, the oral board traps. We've seen these three consistently sink otherwise excellent candidates.
Trap 1. You deliver a perfect discussion of your toxicity management plan dysphagia, ORN xerostomia, but you forget to mention the long-term endocrine issue.
The recovery move. If the neck was irradiated, TSH every 6 to 12 months has to be stated automatically in your answer. It shows comprehensive awareness of survivorship issues beyond the acute treatment site.
Trap 2. You discuss parotid sparing vaguely. You say something like you try to keep the dose low or minimize dose to the contralateral parotid.
The recovery move. Boards want to hear the specific board-defensible number, meaning 1 parotid under 26 grays. If you can't cite the number, you haven't mastered the concept.
Trap 3. You discuss chronic dysphagia, but you fail to name the specific driving anatomical structures and their associated constraints.
The recovery move. Your dysphagia answer has to include constrictors mean under 50 gray when feasible, and larynx mean under 44 to 50 gray with larynx V 50 under 27%. You have to connect the functional failure to the compromised anatomy.
All right, let's solidify 6 high-yield clinical pearls that really encapsulate today's discussion.
Pearl 1. Survivorship in OPC is entirely DVH-driven. You have to connect the patient's functional complaint directly back to the physical constraints used in planning.
Pearl 2. Salivary anchors define quality of life. Mean 1 parotid under 26 and mean 1 submandibular under 39 gray. You fight for one of each.
Pearl 3. Swallowing anchors for functional preservation. Constrictors mean under 50 and larynx mean under 44 to 50 gray, with that practical larynx V 50 under 27% handle.
Pearl 4. Mandible risk is all about high dose and hotspots. Mandibular Dmax must be controlled around 66 to 70 gray with volume control, aiming for V60 under 24%, coupled with lifelong dental vigilance.
Pearl 5. Thyroid surveillance is mandatory after neck irradiation, regardless of the target volume or modality. TSH every 6 to 12 months.
Pearl 6. Modality counseling is based on treatment intensity and dose distribution. Selected unilateral adjuvant pathways, so TORS-based, generally preserve function better due to better OAR sparing capability and functional redundancy.
Time for the boardplets. 3 questions to solidify the key concepts.
Let's do it.
Question 1. Salivary constraint. You're planning definitive chemoradiation for a bilateral neck or a pharyngeal case. What's the most board-defensible salivary constraint anchor to cite? A. Mean oral cavity under 20 gray. B. Mean 1 parotid under 26 grays. C. Parotid D max under 50 gray. Or DV60 of submandibular under 10%.
The best answer is B, mean 1 parotid under 26 gray. The rationale is that this is the classic conventional fractionation anchor, representing the lowest threshold for meaningful function preservation.
Perfect. Question 2. Dysphagia prevention. Which constraint pair most directly supports a survivorship-focused dysphagia prevention strategy? A. Brainstem Dmax under 64 and optic nerve Dmax under 56. B. Larynx mean under 44 to 50, and constrictors mean under 50 when feasible outside the high-dose target. C. Mandible Dmax under 66 and parotid mean under 26. Or D. Esophagus mean under 34 and cochlea mean under 45.
The best answer is B. The rationale there is that the constrictor and larynx constraints map directly to the anatomical structures responsible for preventing bolus residue and aspiration, which are the main modes of failure in OPC survivorship.
Exactly. Last one. Question 3. Survivorship diagnosis. A patient 2 years after oropharyngeal chemoradiation is fatigued with constipation and cold intolerance. There is no evidence of recurrence. What is the next most appropriate step? A. Order a PET CTB. Start an empiric antidepressant. C-check TSH. Or D, refer for a feeding tube?
The best answer is C, check TSH. The rationale is the patient has classic symptoms of hypothyroidism after neck irradiation. It's common, easily diagnosed, and treatable. You always rule out treatable endocrine dysfunction before escalating to more invasive or systemic treatments.
That brings us to the end of this discussion on OPC, functional outcomes, and survivorship. We really focused on that constraint-first approach, recognizing that the DVH is the patient's functional story.
We anchored outcomes in our two contrasting cases, illustrating why definitive bilateral chemoradiation commonly produces more chronic xerostomia and dysphagia than selected unilateral adjuvant pathways, and those findings are supported by studies like ECOG 3311.
And let's just quickly recap the non-negotiable numerical anchors one last time. Fight for mean 1 parotid under 26 gray and mean 1 submandibular under 39 gray.
And protect the swallow structures, mean constrictors under 50 gray, larynx mean under 44 to 50 gray, and cord Dmax in the 45 to 50 gray range. Survivorship is a commitment to lifelong functional monitoring.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next series entry. Thanks for tuning in.